next session, which is going to be looking at research evidence on COVID and long-term care during the pandemic and its use in informing responses. And we're going to start with the first look at the issue and the evidence that we have in relation to family visits to care homes during the pandemic, focusing on the UK evidence. Then we will have a paper that I'm part of, so of course I'm very enthusiastic about, with my colleague William Byrd, where we've conducted a mapping to see how the evidence base grew during the first year of the pandemic. And then we will hear from Oscar Brito Fernandes on the partnership between academics and policymakers in responding during the pandemic. Another very interesting episode. So thank you all. And I think I saw Alex Hall earlier. I think you're there somewhere. You want to start sharing your screen? There you are.
Yeah, I'm here. Thank you. Can you hear me okay?
Yeah, thank you.
Yeah, excellent. Okay, thank you. Yeah, I will just share my screen. Okay.
Great.
Okay. Yeah. Is that okay? Okay. Yeah. So, hi everybody. I'm Alex Hall from the University of Manchester and the NIHR Older People with Frailty Policy Research Unit. This is a collaborative research unit involving colleagues from Manchester, Newcastle University and LSE. I'm just going to talk very briefly today about a piece of work that we did earlier in the year that was a very sort of rapid response piece of work that we were asked to do. To look at experiences and perspectives around family visits to care homes, policies and practices during the COVID pandemic. So this is a UK focus, but I'm sure some of the findings will be very transferable and familiar to colleagues in other countries. So just a bit of a background to the study. So in the UK, we have about 500,000, just under 500,000 adults living in care homes, and care home residents' deaths have made up 1/3 of all COVID-19 deaths. We first had a national lockdown on the 24th of March 2020, and following that lockdown, visits to care homes were very strictly curtailed. And since then, there's been a lot of very changeable policies and guidance that have been pretty challenging to keep up with, I think it's fair to say. So at the beginning of the year, we were approached by the Department of Health and Social Care, Public Health England and the SAGE Social Care Working Group. So this is one of the subgroups that feeds into our National Scientific Advisory Group, to look at research exploring experiences and preferences of staff, families and residents on visiting during the time of the pandemic. But it was agreed that what we needed to do was a rapid scope of current ongoing research so that we could map what was actually happening within our country at the time. So we started looking at what we already knew at the beginning of the year. There were two major pieces of work that we thought were particularly applicable. So the first was work conducted by colleagues in the Applied Research Collaboration, the East of England, and Care Home Research Collaboration Network. They published a series of 8 rapid expert reviews of evidence, producing top tips for practice in response to a lot of questions that were being asked by care homes at the time. And there was a real standout quote from some of this work was that there was a lot to say about what care homes should do, but far less about how they should actually do it. One of the main points highlighted in this work was the risk of information overload for managers and staff trying to implement a raft of rapidly changing policy guidance with little resource. The other major piece of work was published at the start of the year by colleagues at the International LTC Policy Network with a review of international guidelines and emerging practice on safe visiting. And you can see some of the major recommendations from that piece of work here. Critical about blanket visitor bans, a need for more local determination of what constitutes safe practice, more emphasis on family carers visiting, funding concerns, and queries about the role of sector regulator in overseeing visiting practice. But a lot of this work was not from the UK, and also given at the time it was published, there was quite a lot of work in this, was opinion pieces, expert commentary. There was a whole lot of different types of resources that were summarised in this. So we wanted to look for potential studies within the UK. We had only a very few weeks to do this. So we wanted to look through very quickly through web searches and through using our professional contacts and networks. And once we'd identified studies, we then contacted lead investigators, asking them for further information, including any key interim findings that they might be able to share. So we were interested in studies that had started in March 2020 or later, and because we were looking for people's perspectives, we were interested in studies using review methodology, qualitative approaches, or surveys. We were interested in studies that had not yet been published in peer-reviewed papers. So it was either studies that were in progress or studies where funding had been secured and they were shortly due to start. So this was a very rapid search conducted in February this year. So we've not captured any sort of local audit or evaluation work that might have been going on, and we haven't done any quality assessment of the research that we found. So this is just a list of the resources that we searched. We were extremely grateful to the work by colleagues through the LTC Covid resource and the database of research that they were compiling at the time. That was a great starting point. We searched the websites of other major funders in the UK, many of whom quite helpfully have sections on their websites that highlight Covid research specifically, and also some preprint sites as well there. We found 17 ongoing studies in the UK, all studies exploring the experiences of staff. About half were involving relatives, and one was aiming to involve residents directly. The vast majority of the studies were externally funded, but there were a couple that had received internal grants from their own institutions. I don't expect people to read this slide, but this just summarises the titles and the lead investigators of the study. When we presented our report, we organised them by completion date. So most of the studies are now just about finished or are coming to an end. The last three on the right-hand column are still in progress, and particularly the last study on the list, led by Josie Dixon at LSE, is really addressing this question about responses to visiting guidance in much more detail. So I think that is the one to look out for in future from the UK perspective. So just to summarise some of the findings, areas of focus of the studies. So a lot of this sort of very much spoke to the previous work that I highlighted earlier. So there were concerns around differential impact of visiting restrictions, concerns about human right to family life had not been adequately balanced against risk of infection. Concerns about the impact on residents with cognitive impairment and dementia, and how appropriate different forms of visiting would be to those people. So remote visiting, socially distanced visiting, window visits, as they've been called in the UK, pod visiting, those kind of things. How far residents would actually be able to understand those, and whether they would become distressed by those forms of visiting. And some work highlighting that a lot of these different alternative forms of visiting are actually quite heavily impacted by the physical layout of a care home, which may determine what sort of visiting is actually possible and how far homes are able to facilitate alternative options. There were quite a few points raised about PPE equipment and testing. So we know that provision of PPE to the sector has been sporadic and rationed, certainly at the start of the pandemic. Some evidence of inflated costs. Perceptions among care home staff that the health service was prioritised, and they may have seen on television or in the media the sort of PPE that colleagues in the NHS were wearing, and maybe contrasted that unfavourably with what they themselves had been given. And the couple of points at the bottom there just sort of really highlight the fact that the constantly changing guidance and the new practice that was required to be implemented may actually be really resource intensive for homes, and the questions about how feasible it would be for them to continue to adhere to constantly changing guidance, particularly around visiting associated with rapid testing, like how feasible would it be for homes to implement that. And then there were findings around the role of relatives and good communication. So people initially understood and accepted visiting restrictions, but as time went by, this became more distressing for relatives. Lack of clarity in the guidelines, the alternative options that were offered may have been perceived as inadequate. And this frustration particularly amplified when people were seeing other sectors of society opening up and wondering why care homes were still under much more strict lockdown restrictions. And work highlighting the need for trust and clear communication between homes and families, but with some concerns about alternative forms of communication at end of life, the extent to which, for example, remote communication is ethically suitable or appropriate is being explored further. And so we also wanted just to highlight where we thought the main research gaps were. So we highlighted 4 main areas. So I think that the finance and resource implications are particularly interesting. Some studies that are looking at implementation more broadly are likely to be looking at these as part of that broader focus, but it's possible that more explicit work might be needed on the finance and resource implications for care homes in implementing visiting guidance. A greater focus on the role of other stakeholders within the care system more broadly, and the relationship between the care home and organised stakeholders such as the regulator, PPE suppliers, etc. At the time we did this piece of work, the vaccination programme in the UK was just getting underway, so there weren't really any perspectives on vaccination that were captured at the time. So more work on this topic may be useful. And then also the influence of care home characteristics in terms of as I've already mentioned, the physical layout, but the type of home, the size of home, the type of care provided, all these, whether they're privately funded or not-for-profit homes, all these type of characteristics may be more important to unpick further. A lot of the studies, because they got up and running quite quickly, they were involving quite low numbers of homes and participants. But some of the newer studies that are still ongoing are, I think we'll be looking at this in more detail as they have larger samples. So I will end there, just to say thank you. I've already mentioned the work of colleagues of the LTC Covid resource was hugely helpful in this piece of work in giving us a real head start in identifying the ongoing work. And also a big thank you to the lead investigators we contacted as well, who responded to us very, very quickly and were very generous at sharing information which can be quite sensitive when you've just set up a study and you haven't actually really got your findings yet. But people were very generous and it was a real sort of collaborative effort. So I will end there. Thank you very much.
Thank you very much, Alex. And as we are on the theme of how the evidence emerges, I think it will be a good combination to now go on directly to Will's paper, and then we will have the sessions at the end. So my colleague, William Byrd, is going to present a mapping of the evidence of how it evolved during the pandemic, and the title is "What Long-Term Care Interventions and Policy Measures Have Been Studied During the First Year of the COVID Pandemic." So Will, all yours, if you want to share your screen, see if it works.
Thanks, Adelina. I'm just going to try and share my screen now. I also woke up with quite a sore throat, so sorry for that as well. So is that working okay?
Oh, soon, I think. Yes, perfect.
So that works. Perfect,
Yes, it
thank you.
works, yes.
So as Adelina said, her and I worked on this paper at LSE, and it's looking at what long-term care interventions and policy measures have been studied during the COVID-19 pandemic. Also, as we know, deaths from COVID-19 have been concentrated among people using long-term care, especially those within institutional settings. And consequently, measures have been implemented to prevent infections or manage the consequences of COVID-19 in institutional and home-based care settings, going beyond existing infection prevention and control protocols. While some measures reflected high-level policy changes at the national level, others were implemented pragmatically by care providers ahead of official guidance. In response, researchers made efforts to rapidly assess the effectiveness of some of these measures and generate timely evidence to inform the pandemic response. This involved adapting and reorienting existing studies, as well as responding to new funding calls. And given the rapid nature of the development of this new area of research, it can be expected that there is an uneven evidence landscape. So we aimed to map the international evidence published during the first year of the pandemic, and we adopted a pragmatic approach that allowed us to rapidly identify emerging evidence rather than one aimed at exhaustively documenting all long-term care-focused studies. Weekly database searches were conducted from April through December the 31st, 2020, and studies were included that provided original data on any intervention or measure that was implemented in response to the COVID-19 pandemic in a long-term care population, or original data on possible targets of such measures. And our database searches identified 11,715 results. Screening the titles and abstracts of these results identified 10,865 as not relevant for long-term care and COVID-19, and the remaining 850 studies were downloaded and full texts were reviewed. There were then 713 that were excluded, leaving us with 137 included studies. Included studies were conducted in 22 countries. Most studies were from the United States. There were 11 studies from the United Kingdom, and only 4 studies were from low and middle income countries, 2 studies from China, and 1 each from Brazil and Cuba. There was a strong focus on institutional care, with 95% of studies focusing on this setting. Most of the studies only provided a narrative account, and few used a control group or other comparative analytical approaches. We then categorized the measures identified within these studies, adapting an existing taxonomy developed by the LTC Covid collaboration. So of the 137 included studies, 50% reported on interventions for preventing or controlling COVID-19 infections, most of which were focused on institutional care settings. The majority were descriptive studies of multifaceted outbreak responses, ranging from outbreak reports of individual care homes to case studies at a national level. The most common interventions were testing approaches, which varied between care homes. Basic testing is limited to screening symptomatic cases, missing asymptomatic cases. A more thorough approach involved repeat universal testing, undertaken until there are either no new cases or until everybody in the care home tested negative. Pooled testing was used to preserve resources when there were no current cases, and antibody detection was used in conjunction with testing for diagnosing those with a low viral load. Cohorting and isolation were commonly used to limit the spread of the disease. Isolation was undertaken to prevent infected residents from leaving their rooms, which sometimes included those who'd been exposed. Some facilities isolated new admissions before they were allowed to integrate. Cohorting enabled the spatial separation of infected residents from the rest of the care home, with separation sometimes done in special facilities. And in addition, selected groups of staff were sometimes cohorted with specific groups of residents. Several measures aim to reduce the risk of infection from staff. Symptom and temperature screening before shifts enabled symptomatic staff to be identified, although this was unable to detect asymptomatic staff. In some cases, staff were isolated on site or in hotels to reduce the risk of infection transmission. Infection prevention and control protocols that were implemented early on in response to the pandemic included measures such as social distancing, use of personal protective equipment, enhanced hygiene, closure of communal areas, and restriction of activities in care homes. These IPC protocols were then often implemented through training interventions. Several studies reported on measures to treat COVID-19 or improve access to general health care for people living in institutional care settings. Although pharmaceutical interventions were identified, none of these were randomized controlled trials. Non-pharmaceutical interventions included the creation of contingency plans to maintain access to general health care, and telemedicine by video call or telephone was used to reduce in-person consultations. Studies were identified to analyze possible targets for interventions, such as ownership structures, quality of services, and staffing policies. Some studies found that private ownership was associated with more infections and higher mortality, which is often related to a lack of PPE. Some studies found that high nursing home quality ratings were associated with fewer infections and lower mortality. And other studies found that cases or deaths were instead associated with care homes being part of the chain. Higher staffing levels were often found to be associated with fewer infections and lower mortality, reflecting the need for sufficient staff to implement IPC or cohort patients. And additionally, resource availability was important, with PPE shortages being associated with more infections and higher mortality. Several studies reported on policy and governance, with the majority of these being descriptive, regional, and national case studies. The regulation and oversight of social care services was analysed, which highlighted the number of available beds and the maximum occupancy of nursing homes were associated with the number of infections and mortality. COVID-19 specific measures varied between countries, with strict IPC policies and more robust responses leading to fewer infections and deaths, although implementation was dependent on resources. Studies from Hong Kong and Taiwan highlighted local preparedness following the experience of the SARS pandemic, and this included convening central command centers, which utilized strict emergency response plans to effectively manage the pandemic and protect nursing homes. And finally, numerous studies focus on data and information communication technology. Care home residents were sometimes supplied with technology to enable them to maintain social contact with either families or dedicated volunteers, and electronic health record data enabled the efficient admission of residents, allowing the history of patients to be tracked. During the first year of the COVID pandemic, a substantial body of evidence on interventions to mitigate impacts of the pandemic in the long-term care sector emerged. Our mapping review found that in the first year of the pandemic, the state of evidence was poor overall, reflecting both the time it takes to generate evidence and for it to be published in the crisis context in which most of this research was carried out. Despite identifying 137 studies reporting on a variety of different types of interventions, most studies did not apply an analytical lens and instead provided descriptive findings only. Our review also identified an important evidence gap in relation to non-institutional care, despite growing evidence that unpaid carers and people using care at home have been severely affected by the pandemic. Findings from this mapping show that only low-quality evidence on measures to prevent and mitigate COVID-19 in the long-term care sector was available to guide decisions on how to respond to the pandemic. While particularly at the beginning of the pandemic, this was inevitable due to the presence of a novel virus, there may be scope to learn lessons from the scientific response to the pandemic in relation to long-term care and to consider the role of research in future pandemics or other major emergencies. This may involve assessing the degree to which the existing research infrastructure was able to support the rapid generation of evidence to assist decision-making during the pandemic, and identifying opportunities to both strengthen the long-term care evidence base and have better research preparedness for future events. Comparatively, the healthcare sector was able to respond more rapidly to the pandemic, partly enabled by existing mechanisms for global research coordination during public health emergencies. Our review also indicates a possible geographical imbalance in research capacity. Only 4 studies were identified from low and middle income countries. Histories of uneven development and unequal exchange have constructed relationships of dependency, which make the Global South vulnerable to disrupted funding streams caused by emergencies, such as the COVID-19 pandemic. And so there's a need for the Global South to further develop robust research and implementation capacity that is independent of the Global North. And this should be supported by unconditional financial capital and the free sharing of knowledge and technology. We focus on English language databases only, and so the findings of this mapping review may not be representative of the global literature. Furthermore, the classifications that we use to define types of care reflect care systems that are present in the global north. These were instrumental in developing our search strategy, enabling us to identify relevant search terms. And so representation of the structure of long-term care provided in the global south would enable a more inclusive search strategy. Finally, as of September 2021, the search strategy for the mapping review has been updated to identify the scientific evidence published during 2021. Thank you.
Thank you very much, Will. And so the idea is that we will have a comparable paper at the end of, with all the research up to the end of 21, and your voice managed to hold up, thankfully, just until the end. Well done. So we're now going to go to Portugal, and we're going to hear from Brito Fernandes. That's quite a different paper, but it's also very interesting to look at the relationship between academia and policymakers in the response and the support for care homes in Portugal. So Oscar, all yours.
Thanks, Adeline. Let me do if I do it right. Can you see this client's full screen?
I think it's coming. Just let's see. We can't see it yet, but it says you are sharing. So. Yes.
Okay.
We can see it well. Thank you.
I learned something today. In addition to the swap displays that I learned it today as well, Adeline. It was not only you. So I'm happy to present to you the work that we've been conducting since March 2020 back in Portugal with the Algarve Biomedical Center, which is a structure of the University of Algarve in the south of Portugal, where we've been partnering up with policymakers in responding to the challenges that COVID has imposed to nursing homes. But before I move ahead with the presentation, I would just like you to imagine, like in the beginning, there is nothing. Imagine that nursing homes start listening to news about a pandemic, that nursing homes, their managers, families, residents start listening that this pandemic actually affects more severely the elderly. Imagine that there's little or none information and guidance of governing authorities. So imagine the burden and the feeling of emptiness and hopelessness that these facilities faced in the beginning of the pandemic. So in order to address that, because we were understanding that in the beginning, there was a little response by the government towards supporting these structures. In the Algarve, we started a process of combining both testing to residents and staff, but also aligning that to an approach that of being closer to nursing homes and actually listening to them and to their fears. And that's why we developed this study of better understanding the COVID-19 preparedness of nursing homes in the south of Portugal and explore the effects of COVID-19 preparedness in terms of the safety culture and well-being in these structures. I won't provide a lot of details. This is just a bit of grounding to further explore the partnership that we developed with the government, specifically with the Ministry of Labor. Because I had the pleasure of sharing the findings in a more lengthy manner in a webinar that Adelina invited me back in July, and that is available. But also in the slides, when they are available, you have a link to the peer-reviewed paper that illustrates all that we did and kind of supports scientifically our choices. But briefly, this is the study design. So there was a testing capacity where we are testing both personnel and residents. At the same time, we're working with managers and trying to understand the contingency programs, trying to understand basically the fears and the anxiety of staff, and that's why we conducted a cross-sectional survey. And basically, our overall findings is that there was, of course, unpreparedness across all nursing homes, specifically in terms of how they were dealing with outbreak capacity and in terms of being able to support their staff with education and training specifically to work in nursing homes under these very particular conditions. And often when we analyzed all available contingency plans, we've seen that poor communication channels were often the case, insufficient planning to address uncertainties. There was a lot of misuse about and misconception about personal protective equipment, but we've seen a lot of good practices as well, and we tried to share that with all nursing homes that we were in contact with at the time. But basically, our results support that regular testing was important, in fact, to basically identify early cases of infection and to avoid surges, but it was not sufficient to limit the effects of anxiety in staff. At the same time, and this was the first study that was conducted in nursing homes in Portugal in regard to safety culture, we've seen that compliance with procedures and non-punitive responses to mistakes were signaled as needing improvement the most. So combining these findings, and because we were already in connection with the government, specifically with the Ministry of Labor, Solidarity and Social Security, because we were testing residents and staff in nursing homes, which is under their oversight, we were challenged to come up with a solution, a nationwide solution. And our solution was first and foremost to deploy a support line available 24/7 to all nursing homes in Portugal. And why was this the solution? First of all, it was easy to implement. We could reach every nursing home. And the first thing that these nursing homes and managers and families, what they needed was to have someone that they could actually call and ask for advice and ask for information that they could share their experiences, their anxieties. So that's why we set up a national support line for nursing homes. The volume of incoming calls, they are mainly coming from major cities, that is Lisbon, Porto in the north of Portugal, to a less extent from the interior, the inside of Portugal, but that is, of course, and this was highlighted by the colleague that shared the ECD data, that this is very much related with the capacity of the facilities. Thus far, we have received more than 3,500 incoming calls from nursing homes for various reasons, but we've been quite proactive. So more than 17,000 calls have been made just for regular check-in. How are they doing? If they need something, if they have sufficient supplies in terms of PPE, if they are being tested, follow-up cases, in cases of outbreaks, we'd follow up with managers trying to see if they have been tested, the residents, our staff doing regarding that in terms of anxiety. Basically, and this was very key for the success of the line in regard to the support that was provided, was streamlining the communication among stakeholders. Streamlining the communication among nursing homes, their needs, and the Ministry of Labor, and the component authorities of health. So this was key to basically address in a quick manner the needs of nursing homes. This was not only sufficient, and we've seen that one of the gaps was about training. So we developed a training solution, and that was a short-term capacity training for working in nursing homes in times of a pandemic. We gave a bit of thought about this, how to actually launch this program so we could have the greater impact possible. So we thought about it and we designed it as a 5-day training, where the initial 3 days, they basically are online, so they can take it whenever they want. Actually, in those 3 days, in those initial 3 days, they have a synchronous session with the doctor where they actually can go through. It's also a very cathartic moment where they go through the experiences, because often staff, they have no one to speak about the struggles and the experiences. So this is an opportunity they have to actually explain to someone that is able to translate and give meaning to their experiences, and saying that it's okay, whatever they are experiencing, that it's okay to fear, that it's okay that you are feeling stressful, and trying to develop mechanisms to cope with that and still work under those circumstances. The topics were various, so we provided background information on the virus, but also on vaccines, we've seen some resistance, of course, with vaccines, but also try to staff to better understand what PPEs are and how are they used, how different PPEs are used for. And then the 2 days, a trainer goes actually to a nursing home, and with a group of 10, 15, the most that we can deal with, and also because of security measures, for safety measures, it's 20 people in the same room. Basically, we have a trainer there that is teaching them how to best use in an effective manner PPEs and gowns, etc. So, and of course, we also use all the resources that are available nationwide to all nursing homes. And at the moment, we are also maintaining a YouTube channel where we share all the video materials. We actually filmed a lot of these materials, just detailing how to best use checklists, how could they implement and embed in their facilities, the use of checklists, for example, for washing hands, which is very important. And the impact has been quite surprising, and more than 2,000 nursing home staff have already been enrolled in this program. Later, we decided that we had to do something more proactively in preparing for winter. We didn't know what was actually going to be the surprise that was waiting for us during winter time. That's why we developed a platform and an online platform to support the monitoring of symptoms and early identification of respiratory infections. So we didn't want to build a resource that was only COVID-19 oriented. We wanted to broaden its scope, especially with the flu season that it's coming in. So it's a platform where basically nursing home staff can insert data on the residents about oxygen saturation, temperature, and respiratory frequency, and previous conditions, specifically infection or respiratory conditions. And basically an algorithm just gives an alarm for each of these symptoms, saying that based on those measures, and considering previous measures and what are regular measures for that population, and considering the characteristics, if it's required an urgent intervention, that probably is called the emergency line, or just called a doctor and monitor closely that resident, or if it requires active monitoring for symptoms. So probably, and we always suggest that please do a lot of measures throughout the day, just to make sure what is the evolution, or if it's just a normal status. The approach and the use of nursing homes of this platform has been quite varied. Some of them focus only on residents that are at higher risk. Others focus only on those that have already a previous respiratory condition. So basically, they embed in their own culture and using their own needs to appropriate this platform in their daily works. So currently, more than 140 nursing homes in Portugal are using on a daily basis the platform. Some are not really, but one of the challenges is how technology is embedded in these facilities. So we were not expecting actually a huge response across all nursing homes, but we are very happy with the numbers, and we are doing an effort so this could be used across a much larger number. More than 3,000 residents are actually being monitored currently with the platform. We set up a distribution program of oximeters. Most nursing homes had, but some of them only had one for like 50, 100 residents. So we set up a program to distribute oximeters among public nursing homes. And we have already collected more than 65,000 data points, health data points from residents that are being monitored by the platform. And at the moment, the national support line is also being used, and this is very recent, to channel, basically monitor all active outbreaks and try to streamline the communication among authorities, so these outbreaks are addressed in a timely manner. So currently, all academic centers that are running tests and are actually testing in a routinely mannered staff in all Portugal, we are receiving the results, and whenever we have positive results, the support line is alerted to that and activates all emergency authorities so they can quickly act upon this. And this is just an illustration of the team in its very beginning in March, April 2020, when we were very naive about what was happening. We are set in a stadium in the south of Portugal. Nowadays, with relaxation of measures, we have to share with some football matches as well, the stadium. But we are still there and very happy to be of use to support nursing homes, their managers, and residents and families throughout the pandemic. Thank you for your attention. I'm willing to receive any questions here or by correspondence. Thanks.
Thank you. We're a bit short of time, and I think people will need a short break before we go on to the next session. But if you perhaps any question could go onto the box, that would be great. And I did notice you had a retweet from Mariah Carey. I mean, that's so my colleague, but congratulations.
That was the highlight.
Yeah, but no, seriously, congratulations on such an amazing mobilization. And you know, it is really research for the public good. So we're going to take a break. Great to see some of the next speakers already having joined us.